Welcome everyone to the tobacco-free RNAO webinar, Pharmacotherapy for smoking cessation. My name is Nicole Jeffrey, and I am the Implementation Specialist for the Tobacco Intervention Initiative at RNAO, and I'm going to be moderating today's webinar. RNAO is a professional association for nurses in Ontario and promotes excellence in nursing practice and advancing nurses' contribution to the healthcare system. RNAO has a signature program called the International Affairs and Best Practice Guidelines Center that develops, disseminates, implements, and evaluates clinical and healthy work environment best practice guidelines. The focus of our program is the newly revised and published Best Practice Guideline integrating tobacco interventions into daily practice. As part of our Tobacco Intervention Initiative, we hold regular webinars to build capacity among nurses and other healthcare providers to implement and sustain best practices in regards to intervening with clients who use tobacco. So just for today's webinar, just sort of some housekeeping. Before we begin, just to make sure that in order to hear the audio for this event, this will come through your computer speakers. So if we ask that you please turn up your speakers to be able to hear the presenters accurately. And just so that you're aware, if you have any questions during the webinar, to please enter them into the Q&A section that you'll see at the top of your screen. If you click on the button, you'll be able to enter in the questions there. And just to be mindful of who you are selecting when you are asking your question, whether you want it to go just to the panelists or whether you want everyone in the chat group to be able to see the question that you're asking. So this question and answer section can be used for any logistic questions that you have if you're having trouble hearing, or if you have any just general questions that you would like to ask Steve throughout the presentation. The last 15 minutes of the webinar we are going to be using to answer any of these questions or comments. In addition, throughout Steve's presentation, there are a few case scenarios regarding the use of nicotine replacement therapy. If you have any questions regarding these case studies, we're going to be taking these up within the last 15 minutes of the webinar as well. So, here today, do you mind going to the next slide for me, Natalie? Yeah. There we go. So here presenting for us today, we have Steve Alexander. Steve Alexander is a registered pharmacist at Findlay's drugstore, New Liskeard, and is a certified tobacco educator. He completed his Bachelor of Pharmacy at the University of British Columbia and spent the first 4 years of his career working in addictions and mental health pharmacy services on the downtown east side in Vancouver. Steve now works as a community pharmacist at an independent pharmacy in Northern Ontario. He was previously an elementary school teacher and loves combining his old and new career to ensure his patients understand their medication and therapies to achieve the best possible outcomes. So welcome, Steve. We are very pleased to have you here with us today. I will now turn it over to you to start the presentation.
Hi, can everyone hear me? I guess so. Okay, so thanks for the introduction. My name is Steve, as she said. We'll just get right into it. This is my first webinar. I normally do live presentations, so here goes. So the goals of this webinar today are to reduce the symptoms of nicotine withdrawal, making it easier for the smoker to stop using cigarettes. And smokers who wish to quit should be managed with a combination of behavioral therapy, and pharmacotherapy. So we're all here to try to get people to quit smoking. It takes people on average about 7 times to quit smoking. So it is a bit of a grueling process. Some people can quit cold turkey with no help. Other people need some pharmacotherapy, other people need behavioral therapy. What they found works best is a combination of pharmacotherapy to deal with sort of the physical addiction to nicotine, as well as behavioral therapy that will deal with the habitual part of smoking cigarettes. The medications that we'll be going over today, we'll be going over with straight nicotine replacement therapy, which will for now be known as NRT. Varenicline, which the brand name is Champix, Bupropion, brand name Zyban, and a newer medication to the market called Cytisine, and it's also known as Crave. This is not, Crave can be picked up by most pharmacies. It's actually just been brought into the country by a young pharmacist out of the University of Waterloo in the past 3 or 4 years. There's not widespread distribution of Crave, but it does have some promising results, and we'll go over it as a potential, other over-the-counter therapy for your toolbox when you're dealing with people that are trying to quit smoking. Okay. So I'm just putting my timer on here so I can time how long I've been talking just to make sure I don't go overboard. Okay, so when you're looking at someone comes in and they want to talk to you about quitting smoking, the first question you ask yourself is, what medication do I choose? You've assessed them. You've decided that pharmacotherapy is going to be appropriate for the patient. So when it comes to someone just, coming off the street, they're not pregnant, they are just the average Joe that's looking to quit smoking, all of these are first-line options. The choice is based on patient preference. The choice is also based on cost. When you're looking at NRT, the generic brand can cost anywhere from $45 to $90 for a 28-day supply. When it comes to Varenicline, Varenicline is only brand name. It's about $120 for a 28-day supply. There are cards that you can get from the manufacturer that generally will take a half price off of the first dispensation, so that would be off the starter kit. And the one thing I think you'll have a hurdle that you'll need to jump over when it comes to dispensing Varenicline is almost like thinking it as a capital expenditure for the patient. Most of the time, the people don't really think about how much they're sinking in to their habit on a monthly basis because they're picking up a pack here and a pack there and a pack here. Whereas Varenicline, all the money comes up front. So the Varenicline, depending on how much they smoke, generally turns out to be the cheaper option. But sometimes trying to convince the people of that is a bit of a hurdle. There's also Bupropion. It's known as Zyban. Bupropion and Zyban, Wellbutrin and Zyban, they're exactly the same thing. Now you're looking at the slow release, or the SR version of the Wellbutrin, not the XL version. So what they did is they found out that a lot of these people that they were treating for the depression all of a sudden had an easier time quitting smoking. They did some tests and found that it was actually the Wellbutrin that was helping them quit smoking. So like most drug companies do, they took their previous drug, repackaged it, called it something else, and jacked the price through the roof. So you're looking at, say about $100 a month for Zyban, whereas generic Bupropion can run somebody anywhere from $28 to $40 a month. As long as there's no drug company rep sitting here, generic Bupropion can 100% be substituted in for the Zyban. The prescription just needs to be written with the directions of the Zyban and Bupropion SR as the actual order. When you're looking at Crave, which is a newer one, I've never actually had anybody go on Crave. You're looking at $56 or so for a 25-day course. I do have a question here that says, is Cytisine OTC and does not require a prescription? And that is correct. It is a completely over-the-counter product. We'll go over it a little bit later in the presentation. It's been used for years over in Eastern Europe. So the first thing we'll go over right now is nicotine replacement therapy. So nicotine replacement therapy provides nicotine to prevent the withdrawal while the smoker breaks the behavior of cigarette smoking. So the idea is you want to try to accurately match how much nicotine the smoker is bringing in via their smoking habit and replace it with the patch or the gum or the lozenge. You want to go one for one, so they stop the smoking. They still are getting the nicotine, and now we're going to back them off of the nicotine on a a slow, I guess, tapering basis. There's 4 types of nicotine replacement therapy available in Canada. The most common is the patch, and then there's the gum or the lozenge. They work similarly, the gum or the lozenge. They're pretty interchangeable. There's also the inhaler, which is essentially a little stick that you continually put cartridges in, and then they pull on it like they would be pulling on a cigarette. And finally, you have your oral spray. Okay, so nicotine replacement therapy's efficacy. Randomized trial found them superior to placebo, and that's what you see a lot of in these trials. It's mainly quitting cold turkey versus quitting with the help of the nicotine replacement therapy or the Zyvan or I haven't seen too much on the Crave, but so the nicotine replacement therapy does increase chances of quitting twofold. And the best choice is actually a combination of long-acting therapy, which is the patch. So the patch you would put on once a day, and depending on the strength of the patch, it elutes nicotine over a 24-hour period. And then the short-acting, which would be the gum, the lozenge, the inhaler, or the spray, which would help deal with cravings throughout the day. So we'll first go over the transdermal patch. The transdermal patch delivers nicotine continuously over a 24-hour period. It does take several hours to reach peak levels, so the first patch most likely will be a bit of the most difficult one. Having said that, the patient generally has the highest amount of willpower at that time. They've decided to take the plunge and quit smoking. It does have the highest level of compliance. Anytime you can have a patch type thing where they just got to put it on in the morning and replace it the next day, that the compliance is actually going to go through the roof. It's more difficult when they have to remember to take something. Lots of times people will say, I forgot to take my Champix or I forgot to take my Wellbutrin. So the patch does have the highest level of compliance. So you do need to take that into account when you are dealing with the person in front of you. If they aren't going to be incredibly compliant patient, then maybe the patch would be the best choice for them. I know myself, I'm a pharmacist. I spend all day long telling everyone, take your medicine, take your medicine, take your medicine. And I can't even remember to take the multivitamin that my wife has put right next to my toothbrush. I bought a bottle 2 years ago that had 90 in it, and it probably has about 84 left. So I'm not also the most compliant person on the planet either. So the transdermal patch, what you'd like to do is you want to apply it daily to a non-hairy area on the body, okay? And it's ideal if you can rotate spot to spot, okay? The adverse effects are generally skin irritation, and so that's why we'd like to rotate the patch from spot to spot. They have seen vivid dreams or insomnia. The vivid dreams now, they are thinking that the vivid dreams are actually being they're attached to quitting the smoking as opposed to the nicotine replacement therapy, but insomnia can come from it. Nicotine is a stimulating medication, so some people might need to remove the patch overnight as needed. When you're looking at the gum would be your short-acting version of your nicotine replacement therapy. As I said earlier, best used in combination with the long-acting, and it helps deal with cravings. Now, the gum can be used by itself. The idea is that chewing the gum releases nicotine, which is then absorbed through the oral mucosa. So the idea is the peak blood levels are achieved roughly 20 minutes after the first bite, and the idea is they're going to want to try to park it and not swallow what they've just chewed. So they're going to want to use the bite park method of chewing. It should take about 30 minutes to finish one piece, when I'm talking to people, I like to tell them 30 to 45. Lots of times, you know, when we're not timing something or whatnot, and we're actually trying to do it in our heads, 30 minutes can seem like a short period of time when actually it's quite longer. So I do like to be a bit more generous when I'm telling people, you know, take 45 minutes to finish this, and they just keep an eye on the clock. It also allows them to get the maximum amount of nicotine out of the gum. If the gum is chewed too quickly, so if they toss it in there and they go at it like it's a piece of juicy fruit, the nicotine is released too fast to be properly absorbed, and then you end up actually swallowing it. When it goes through the system, it passes in through the gut, gets absorbed, but the liver actually renders it ineffective. So they're in essence wasting that piece of gum. Now, for some people, they just need to chew gum or do something to get their mind off the habit of smoking. So, you know, chewing it too fast might not be a bad thing. But for the people that do actually need the nicotine that's going to be coming with the gum, this is going to render it pretty ineffective. Acidic beverages like coffee or carbonated drinks should be avoided as they decrease the oral pH, and it leads to decreased nicotine absorption. So if they can try to avoid, if they're using nicotine gum as their sole source, if they can sort of try to wait about an hour after they had a cup of coffee, that would lead to the best results. When they're using it as a sort of a craving stopper, I understand that that's not the most practical thing, because a lot of times smokers do have coffee with their cigarette. The coffee could bring on a craving. So they can try it. They'll still get some nicotine. They just won't get as much as they would have if they did it about an hour after they had their coffee or their Coca-Cola. So the adverse effects of the gum would be gastric and esophageal irritation if swallowed. So that also applies to chewing it too quickly. Nausea, vomiting, constipation, that can all come with it, and then a sore jaw. You'd be surprised if you're not a big gum chewer, and pardon me, I'm just getting over a cold as well. You'd be surprised if you're not an avid gum chewer how having to chew that many pieces of gum in a day can actually irritate your jaw or make a sore jaw, almost like if you haven't worked out in months and you decide you're going to get back into it, how sore your legs can be the next day after a big leg workout. The sore jaw generally comes also from chewing a bit too vigorously, so we want to stress to take it slow, okay? And that's why I kind of come back to this, but I always tell them 30 to 45 minutes. I always try to add an extra 15 minutes on there. I find that really slows them down. The gum comes in two strengths. It comes in a 4 milligram and it comes in a 2 milligram. There's both the Nicorette brand gum, as well as most pharmacies or pharmacy chains make their own generic. They work exactly the same. When it comes to the gum, it's a bit different from the patch. The gum, some people might prefer the taste of the generic or the brand. And then the issue with some house brand patches, although they are much less expensive, is that some of them use an adhesive that doesn't stick quite as well. Now that can also extend itself to the Nicoderm. This is on a patient-by-patient basis. I've had a lot of clients come in and tell me that the Nicoderm doesn't work and that our own Option Plus house brand does the trick for them. So if they find that the patch is always falling off, not to revert back to the patch, but just maybe think of something here. If they find the patch is always falling off, a good idea is to try a different brand, or sometimes a Tegaderm bandage over top of the patch can really go a long way. And just making sure that the area is nice and clean and dry. Okay, moving on. There's also a nicotine lozenge. It's quite similar to the gum, but it must be consumed slowly. So again, I go for 30 to 45 minutes a piece. It's beneficial for smokers with sore jaws, dentures, or poor dentition. So if they already have a sore jaw, or they they've got dentures where the gum would stick, or they just don't have good teeth. This is a good alternative for them. The side effects are similar to the gum, so if we can just go back and reiterate the side effects here. So gastric and esophageal irritation if swallowed, and nausea, vomiting, constipation. So the idea, again, is, we'll just move back forward here. The idea is to suck on the lozenge and then park the lozenge, and then suck on the lozenge and park the lozenge, okay? We're trying, by sucking on it, we're just trying to release that nicotine, which when we park it is then going to be absorbed through the cheek. I like to tell people to park it at the side of their mouth, but really wherever's comfortable for most people. The other thing I like about the lozenge is it comes in an extra strength that the nicotine gum doesn't come in. It comes in a 4 milligram, and it comes in a 2 milligram, much like the gum, but it actually also comes in a 1 milligram, and I really like the flexibility that a 1 milligram lozenge allows you, and we'll go over that a little bit later, but I'm a really big fan of giving out the 1 milligram lozenge if the patient is amenable to it. Okay, so we're looking at the nicotine inhaler this time. So the inhaler, as I had said in the earlier part of this presentation, it consists of a mouthpiece that's reusable, and you insert cartridges into it. So the first time you buy the inhaler, you would actually be buying the pack with an inhaler in it, and if the inhaler is still good when you run out of the cartridges, you can buy replacement cartridges, or you can continually just buy the starter kit that has the cartridges and the inhaler. The nice thing about the inhaler is that it addresses the physical dependence with the nicotine as well as a behavioral dependence, which is a hand-to-mouth. One of the biggest things I do hear from people trying to quit smoking is that they don't know what to do with their hands anymore. So it's just become something that they do. It's sort of almost become a part of them. So by allowing them to use this, much like smoking a cigarette, it allows them to figure out what to do with their hands while they're trying to quit. They bring it up to their mouth and inhale it like a cigarette. The vapor is absorbed actually right into the oral mucosa, and a very negligible amount, if any, reaches the lungs. One cartridge would equal about a third of a cigarette. The adverse effects of the nicotine inhaler is, and I've got a good comment here, straws cut up into lengths of cigarettes are also helpful for physical dependency too. That's a fantastic idea. Really, we got to get creative here. Everybody that we deal with will be a different person, and if the nicotine inhaler is not a actual option for them, then straws cut up into lengths, toothpicks, really anything. Get creative, work with the patient, try to figure out what's gonna do it for them. So that's a great idea. So when you're looking at the nicotine inhaler, the adverse effects are mouth and throat irritation. So you're going to see this as sort of a running theme when we talk about this oral nicotine replacement therapy. Mouth and throat irritation, and then some people can actually have a bronchospasm, which is a bit of a closing up of the airway. So it might not be the best choice of smokers with a history of severe airway reactivity. So if they have really bad asthma or even terrible COPD, this might not be the best option because it could end up with some bronchospasm. So in this kind of patient, the straws cut up into lengths would be a fantastic idea. Okay, we're going to go over the spray now. So the spray it comes in a little canister. It's quite similar to the things you'd see back in the day in old movies or the Little Rascals or whatever, where the guy goes up to talk to the girl and sprays the Banaka in his mouth. So it's quite similar to that. They actually just take it and they give it a shake and spray it in their mouth. Each spray delivers 1 milligram of nicotine. The adverse effects, and here's the running theme, mouth and throat irritation. It can cause some nausea, and about 55% of the people that use it experience hiccups. So we don't have too many people that are on this, but the people that we do have that are on this swear by it. So you'll find it's a bit of a niche. When you're looking at comparing it to a cigarette, your rule of thumb is that there's about 1 milligram of nicotine in every cigarette. So each spray is roughly a cigarette. So that's something you should stress to any client that's looking at getting this, because some people can go quite overboard on the sprays. So every spray they have to realize that they have had a cigarette. Something that might have taken them 5 or 10 minutes to get through now is taking them about 5 or 10 seconds. So we'll go through some examples here. Knowing that there is roughly about 1 milligram of nicotine in a cigarette, and you are trying to match up the exact amount of nicotine, or close to it, not the exact, but you're looking at trying to match up the amount of nicotine they were getting from cigarettes with the nicotine replacement therapy. We'll go through a couple options here. I do believe that there'll be some time at the end to go over the answer. There's no real right or wrong answer. As you'll find, everyone that comes in is different. So we'll just go over a couple of scenarios there at the end that'll deal with these. So the first example, we're looking at a 25-year-old 1-pack per day smoker, and this person would like to quit using nicotine replacement therapy. Now in Canada, a pack of cigarettes says 25. Whereas in the United States, I believe a pack of cigarettes has 20, so we're looking at a Canadian pack. So this is a person that smokes 25 cigarettes in a day. The options you're given are the patch, the gum lozenge, inhaler, spray, or a combination. So if you want to jot down some ideas, we can go over this near the end. Like I said, there's no real wrong answer, but we are trying to match up right now how much nicotine that we are going to be replacing. So we're looking at replacing roughly 25 milligrams of nicotine for this patient. And the second example is a 40-year-old male, smokes 2 packs a day. So remember, 2 packs a day is about 50 cigarettes. I guess I've already given the answers in this one. Pardon me, this was a more of a live chat. This is, like I said, my first webinar. So for this 40-year-old, you could use high-dose nicotine patch therapy. There's roughly 1 milligram of nicotine per cigarette. He smokes 50 cigarettes a day. So for this person, there's a couple of options we could go through. The first would be 2 21 milligram patches plus a gum or a lozenge. So the 2 21 milligram patches would give the guy about 42 milligrams of nicotine in the day. And then you could use the gum or the lozenges to supplement for the cravings. You could also use 1 21 milligram patch with a 14 milligram patch, which would be about 38 milligrams of nicotine in a day, and then substitute the rest with the gum or lozenge. Those are just a couple of options. Like I said, there's no real wrong answer. We're just trying to replace, just like it says, nicotine replacement therapy. We're trying to replace the nicotine that they brought in with the cigarette, put them on the patches, and then wean them off the patches. Even though they're getting nicotine from the patches or the gum, they're only getting the nicotine. They're not getting any of the other thousands of chemicals that they're breathing in when they're pulling in a cigarette. Now, we'll just shift gears and move over to the Varenicline, which is also known as the Champix. Okay, so now we're into the oral pharmacotherapy. Varenicline binds to the same receptor in the brain that nicotine binds to, and this produces 2 outcomes. The first one is it blocks nicotine from binding, and it decreases the reward sensation that the cigarette gives the smoker. The second is that it stimulates the receptor to produce dopamine, the same reward transmitter created by nicotine, thereby decreasing the effects of nicotine withdrawal. So let's just talk about real quickly what happens when someone has a cigarette. Dopamine is a reward transmitter in our body that our body loves. It's essentially the sex, drugs, and rock and roll transmitter in our body. So when you have a cigarette, dopamine levels shoot through the roof, and the body loves that. When the dopamine levels come down, the body goes, hey, where's this dopamine? That dopamine stuff was great. I want some more. So that's what ends up sort of causing the cycle of them. Dopamine's high, it's great. Dopamine's low, have a cigarette. Dopamine's high, it's great. Dopamine's low, has a cigarette. So what Varenicline actually does is it actually gives them a baseline level of dopamine that would be higher than the average person. So the body still gets the dopamine that it craves, but they're not having this peak and valley kind of thing that they were having by dosing themselves with a cigarette. It also blocks some of these other dopamine receptors. So the nicotine, if they do have a cigarette, the cigarette's not nearly as pleasurable. And most of the time when you're talking to people who are on Champix allows them to see the parts of smoking or to sort of experience the parts of smoking that they don't like. So before they were able to put up with the smell, or if they didn't like the taste, they'd put up with the taste because they'd be satisfied with the level of dopamine they're getting. Now that the nicotine isn't able to bind completely, and there's also a baseline level of dopamine, they're able to focus on the things that they don't like, so the smell of their clothes or the taste of the cigarette. And a lot of people say they find smoking kind of gross after they start the Champix, and that's what turns a lot of people off. So its efficacy it's been shown to be more effective than placebo, so more effective than essentially cold turkey. Also been shown to be more effective than NRT, and also been shown to be more effective than bupropion, but has not been studied against combination NRT. And the combination NRT is what we discussed a little bit earlier, when you actually combine the long-acting patch with the short-acting gum, lozenge, inhaler, or spray. So all the studies they did on Varenicline was against straight gum, straight patch, just the spray. A lot of companies like to do this because it makes their drug look better. They're not exactly comparing apples to apples, they're comparing apples to oranges. So that's what Pfizer did when they did Varenicline. They didn't compare it against combination NRT, so we don't really have any data versus combination NRT, but we do know that combination NRT is very effective. So this is not saying that Champix is more effective. So when it comes to the administration, the smoker chooses a quit date and starts the Varenicline 1 or 2 weeks before that quit date. So if anybody has actually seen what Champix comes in, you would be, we dispense a starter kit, and it's almost a pre-done blister pack. It's kind of weird. I'm talking with my hands right now, but no one's in front of me. It's a pre-done blister pack, and for the first 3 days, there's in the little area, there's like a sun and the moon at the top. And in the first 3 days, there's only a little white pill, and that is your half milligram tablet. And then for the next 4 days, they would be taking a 0.5 milligram tablet twice a day. So that would be the first week. And then after that, all the tablets are blue. Underneath the sun and the moon, all the tablets are going to be blue. Those are the 1 milligram tablets. So I like to just take it out, and I like to mark when they're going to stop smoking their cigarette. Generally, I give them the 2-week period, and I've found a lot of people, as they've come back to me, they said, as the Champix is built up in their system, all the negative impacts of smoking, or the negative aspects of smoking that we discussed earlier, starts to rear their head, and it's not that difficult for them to stop by the second week. Now that doesn't mean everyone's going to have an easy time quitting by that second week, but you really want to stress that by that second week, they've stopped quitting smoking. Or they've stopped, not stopped quitting, but they've stopped smoking. So what you want to do is you want to reassess after 12 weeks. So it's first dispensed in a starter kit, which is a 28-day pack, and then there's 2 subsequent maintenance packs, which are each 28 days, and they're just filled with the blue 1 milligram tablets. So if they're successfully quit after the first 12 weeks, but they're still sort of wavering, they can do another 12 weeks. There's nothing wrong with that. It does increase the chance of success by doing another 12-week course. Now, the question earlier is, I had from one of the hosts here, is Champix covered for free by Ontario drug benefit recipients? And the answer is yes. The reason I'm bringing this up now is that ODB will only cover a 12-week course of Champix. So if they wanted to do the second 12-week course, it would be unfortunately, on their own dime. It covers it once a year for them, and once that calendar year is up, they can try it again. So, and it's the same with Zyban. So if you have somebody that's on ODB, feel free to, have them get a prescription for the Zyban. ODB will cover brand name Zyban. If they're a cash-paying customer, or if their work benefits have been tapped out from, previous attempts at quitting smoking when it comes to the Zyban, generic Bupropion SR would do the same thing. So, and that's what we end up doing a lot of the times, is just getting in touch with the physician, explaining the situation, and just getting the prescription changed to generic Bupropion to try to save them some money. The adverse effects of Varenicline, it was previously thought to have a lot of psychological effects, so mood changes, nightmares, and agitation. But new studies have now shown that these effects have actually might be causing the quitting of smoking and not so much the medication. So the FDA actually removed, in the States, they removed their boxed warning, which is their highest warning on medications, in 2016. One other thing that it can cause is nausea, so it can be avoided by titrating the dose. Now, just because it's it's not really known to cause the, nightmares or the mood changes or whatnot, if you do have somebody who comes in and they're not in a stable sort of psychosocial condition, Champix might not be the best option at first. It's really good for people who are quite stable. It does play with the amount of dopamine that's in the system. So if you have someone that comes in on a psychosocial basis, or it's more of a psychological basis, and they are a stable patient, then by all means, Champix can be a first-line therapy. If not, something like the NRT or a Bupropion could be a better option for these patients. All right. The Bupropion, now, it's believed to be act by enhancing the central nervous system, both noradrenergic and dopaminergic, and it's a nicotine receptor antagonist. So it can block, similar to how Varenicline works, it can block the binding of nicotine, thereby decreasing that sort of reward cycle that we're looking at trying to break. Its metabolites are also antagonists of the nicotinic receptor. Zyban, as I've said before, Zyban is a sustained-release formulation of Bupropion, and it is exactly the same as Wellbutrin SR and generic Bupropion SR. And I'll just leave those three little dots there, just so we can know that if you do have somebody who's going to be paying for this out of their own pocket, that it's a nice little touch to be prescribing the generic Bupropion SR, as it will do exactly the same thing. But if there's any drug reps listening in on this, I'm sorry, but Zyban's pretty expensive. The efficacy has been shown to be more effective than placebo. Again, most things are more effective than cold turkey. It's less effective than Varenicline and less effective than the high-dose NRT. Most likely less effective than the combination NRT as well. And it's actually possibly more effective in African Americans due to genetic makeup. And that's most likely, I believe, through one of the liver enzymes. I can't remember off the top of my head, but it's not metabolized as quickly in African Americans, so the levels stay up quite high in them, and they actually get some better results. Bupropion, the administration is you start 1 week prior to the chosen quit date, and the dosing is 150 milligrams once daily for 3 days, and then you ramp up to 150 milligrams twice a day for a total of 12 weeks. And its adverse effects, it can decrease the seizure threshold, it can cause insomnia, agitation, headache, and it can cause weight loss. So if you have a patient that, a lot of people will come in and say, look, I want to quit smoking, but I really don't want to put on any weight. And that's a serious concern for them, and we really need to take that as a legitimate concern. None of us really wants to gain weight. I know I don't really want to gain too much more weight, but it can be a good choice for these people that don't want to gain weight. It can also be a good choice in someone that is experiencing some depression. It can be sort of a double whammy medication for them. It can help them quit smoking and help treat their depression at the same time. Now, finally, we're going to talk about Cytisine, which is also known as Crave. It's a new natural health product to the Canadian market. It's an over-the-counter product. It's billed as a natural product. It's a partial agonist at the nicotine receptor, much like Varenicline. It helps block the reward effects of nicotine and decreases the cravings. And it's been available in Eastern Europe for several decades under the brands, and there should be a space there, sorry about that. The brand, one is called Tabex, and another one's called Desmozoxin. Okay. And how do you take it? Well, it's a 25-day course. Now, if you have somebody that you look at, they're quite like me, who are not the most compliant patient on the planet, this might not be for them. It is inexpensive, so they can try. It's a 25-day course. Day 1 to 3, it's 1 capsule every 2 hours while awake. And this is not actually every 2 hours. It's at least 2 hours apart for these capsules. The maximum is 6 capsules in a day, and each capsule contains 1.5 milligrams of Cytisine. Days 4 to 12, we're going to stretch that to every 2.5 hours with a maximum of 5 capsules per day. Days 13 to 16, we're now going to stretch that to at least 3 hours between these capsules with a maximum of 4 in a day. Days 17 to 20, as you can see, we're just lengthening the minimum amount of time allowed between capsules while actually cutting the amount of capsules in a day as well. So this is going to be 4 to 5 hours, maximum 3 capsules in a day. And then the last one would be at least every 6 hours with a maximum of 2 capsules in a day. Once the patient starts using Cytisine, they should begin tapering their cigarette use with the goal of stopping by day 5. The adverse effects would be nausea, vomiting, stomach upset, and sleep disturbances. We'll go over a question we just got there in a sec. The efficacy, it should work as well as nicotine replacement therapy, and there's no evidence of it versus Varenicline or Bupropion. Since it works similarly to the Varenicline, which is the Champix, the same caution in patients with unstable psychiatric conditions must be extended to the Cytisine. It is an over-the-counter product, so there's quite low barriers to trying it. So, I mean, as in anyone, if you have the right patient in front of you and Cytisine seems to fit the bill for them, it's definitely worth a shot, and especially at $56 for a 25-day course. They might have to repeat that 25 days, but especially with this, you know, the price of this medication, it's definitely worth a shot for a lot of clients. Now, when I made this chart, there was no real data on the Cytisine, so it's not included in it. As you can see, the odds ratio increases with a lot of these. Therapies, the nicotine gum being sort of the lowest, and that's because of compliance, placebo obviously being the lowest. The nicotine patch raises it a little bit more. Surprisingly, the inhaler lozenge or spray came out with some better results than the gum, but most likely because they would be using the inhaler or the spray a little bit better, and most people do go through a lozenge much slower than the gum. When we have gum in our mouth, we're conditioned to chew on it. That's generally what we do with gum. So I find a lot of people do take to the lozenge a little easier. They don't mindlessly start chewing it. The Bupropion raises that a little bit, with the combination NRT and the Varenicline being the most effective, and there's not much margin between them. So what to choose? There's a number of things to take into account. Their degree of smoking. You know, if somebody is a really, really heavy smoker, possibly the gum is not going to be just enough to counter it. Whereas if they are just trying to get off those last 2 cigarettes, they've managed to get this far by themselves. Maybe a 7 milligram patch when they only smoke 1 or 2 cigarettes a day would not be the right choice for that person. You also have to take into account preference. At the end of the day, we might have what we think is a better idea for this patient, but if they go home and they don't use it or they can't afford it, then that idea, although it's a better idea, that's all it is an idea. You need to find something that the patient is comfortable using, that the patient can afford, and that the patient will actually use, because that's the biggest idea there, is to make sure that they will actually use it. Compliance. Myself, I know if I had to quit smoking, the patch would probably be the first thing I'd try. I would never forget to take the patch. I'd have to put it on in the morning, take it off the next day. It'd be pretty easy for myself. And you want something that's ease of use. Like, you don't want to give somebody with dentures the gum because it would be difficult for them to use. And finally, as in always, cost. If they can't afford it, they're not going to buy it, they're not going to use it. It's not going to be the best option for them. So there's a lot of things to take into account. We've just gone over all of these scenarios, and just when you're dealing with anybody that would like to quit smoking, it would be good to take into account all of these specific factors. I do have a question here that says, do you need a prescription for all of these, and what is covered by OHIP? You do need a prescription for the Bupropion or the Varenicline. Now, as a pharmacist, I can write a prescription. So if you would like to refer them to a pharmacy, that's something that now we have the ability to do. You do not need a prescription for the NRT. You do not need a prescription for the Crave. So that's fine. But the Varenicline and the Champix, and the Zyban, they are prescription options. Physician, nurse practitioner, pharmacist, they can write those. And then let's see if I can get a slide here. So we've got questions. So I do have a couple more questions to go through. Cardiac patients, can we use Varenicline? The answer is, in cardiac patients, you could use Varenicline. You're looking at the Varenicline is more try to avoid it in people that aren't stable psychologically. If they are stable psychologically, then by all means. But yeah, you can use Varenicline in that. When it comes to the which NRT would we recommend for high-risk cardiac patient? Most likely with a high-risk cardiac patient, I would calculate their amount of nicotine that we are replacing. So, for example, if that smoker who smokes 50 cigarettes in a day, that's 50 milligrams of nicotine. I would then dial back my combination therapy. So rather than going with 2 21-milligram patches, I would like to dial back their continuous release to, say, a 21 and a 14, or even a 21 and a 7. Sometimes people will smoke 50 every day. Sometimes they won't smoke 50 every day. Sometimes they're over sort of shooting as to how many they smoke in a day. The nicotine replacement therapy is safer than smoking. You're not bringing in a lot of those other harmful carcinogens or harmful chemicals. So what I like to do is, if they are like that, I just have them, I dial back on it. So that 50 guy, I might pick a 21 and a 14 and then give him a limit on how many lozenges or pieces of gum that he should be striving for in a day. Are there any contraindications for using the NRT patch and short acting? There's not a ton of contraindications. There are some times when it's not the most feasible thing to use. If you have someone with quite sensitive skin, then the patch is not going to be working quite well. The short acting, like I said, with poor dentition or dentures, that's sort of a hurdle that you got to get over. What we're trying to do, even though giving someone nicotine is not the greatest thing, it is better than smoking. So we do need to make a concession on that part. Can you extend Cytisine to a second month, and how many tablets per day? This question I don't actually know the answer to. What I would think, this is how I would tackle it. Cytisine is quite new here. If somebody needed to go to a second month, I would actually try to find out at what step in the process did they get stuck? Did they sort of, I don't want to call it falling off the wagon, but where did they get stuck? And then I would make up a dosing protocol from there. Most likely start from that section and then work our way down to nothing on a second month. I don't see any real problem using the Cytisine for a second month, but I wouldn't restart it all over at the beginning. I'd find out where they got stuck and then work from there. Any comments on pregnant patients using NRT in the second trimester or onward? Yeah, so the first line therapy for anyone that is trying to quit smoking second trimester onward is going to be the gum. It'll be the short acting. And most of the time, I've come across patients, and I think I've been quite lucky at this. A lot of the pregnant clients that come in and see me, they do have a strong want to quit smoking, for the baby's sake. So nicotine will cross the placenta. The baby most likely won't come out addicted to nicotine, but by replacing their cigarette smoking with the nicotine replacement therapy is quite similar to the cardiac patient. We're getting rid of a lot of those harmful carcinogens or those chemicals that they have by, bring in by smoking. So if patients do need something in the way of a patch, then a low-dose patch can be added as well. That shouldn't be an issue. But most of the time, you're looking at the gum or the lozenge as your short-term nicotine replacement therapy in the second trimester onwards. We have another question here that says, is there a time frame or duration when using the gum lozenges or spray and any long-term effects? There's no real long-term effects. We do have a couple of patients. I have one guy who he's on the gum for life now. He's quite happy with it, though. So I'm not quite sure what to say to him. He's just really happy he's not smoking, but he has no want to get off the gum. So he'll need to watch out. He's chewing gum every day. He will need to take good care of his oral hygiene and just make sure that his esophagus and whatnot's not irritating. But I mean, the guy's been doing this for nearly a year now, and he seems pretty happy. So there's no real long-term effects. Consuming nicotine over a long-term period of time does raise your blood pressure. So, you could look at a blood pressure effect like that. Having said that, they are coming off of smoking, which they were increasing their blood pressure anyways. So the idea is just to try to get them on something that they can to replace their cigarette habit and then weaning them back from there. I've got a question here. What about Champix plus NRT? You can do the Champix and the NRT. There's actually no real problem with it. And this would be for an incredibly heavy smoker. Just knowing the fact that the Champix does already block some of the receptors that nicotine binds to. So if some people need a little push to get over the hump, they can have it. It might make it more effective. It probably won't. They might end up with some of the side effects of too much nicotine in their system. So, racing heart or nausea, excess salivation, that kind of stuff. So, it's on a case-by-case basis, not to be vague here, but some people do still smoke while they're on Champix, and like I said earlier, they just talk about how much they just realize the negative effects of smoking. What's the youngest age these pharmacotherapies are recommended for? When it comes to nicotine replacement therapy, there is no real age limit. Varenicline and Bupropion have not really been studied in adolescents, so anybody under the age of 18. Most of the time when I have a younger person that comes in and wants to discuss quitting smoking, I talk to them about the patch and the gum. Having said that, young people, much like myself now, even though I'm only 37, are not generally known as the most compliant people. So if it comes to the, using the gum, it might not be a great idea. Bupropion potentially could be used in someone that young, but Varenicline has never been studied in someone that young, so I would stay away from Varenicline. But the first line therapy for an adolescent would be nicotine replacement therapy. I read that the patch is safer than short-acting NRT for the high-risk cardiac patient. The patch could be. I just like to go with a lower dose, like I said when I'm talking about measuring out the amount of nicotine. You do end up with a lot of people who say they smoke, less, like they smoke a pack a day, and then they put a 21 milligram patch on, and they get all sorts of side effects from too much nicotine in their system: racing heart, salivation, sweating, nausea, dizziness. So when it comes to high-risk cardiac patient, what I like to do is I like to calculate the amount of nicotine I'm replacing, then dial that back, and just allow them a set amount of short-acting nicotine that they can consume in a day to help them deal with their cravings. Couple of things. Can I share a link with more Cytisine info, and do you have a link for new studies on Varenicline? I can try to find a link on Cytisine info. I got a lot of it from something called the Pharmacist's Letter, and the new studies on Varenicline can actually be found in, the data can be found in UpToDate. I don't know if you have access to UpToDate, but if you look into smoking cessation on UpToDate, a lot of the studies, the newer studies on Varenicline, can be found there. I have a patient who has tried Wellbutrin and Champix and has not had success in either. He would like to try something again. Is there a limit on how long someone can be on Champix, or limited attempts? Most of the time you see Champix, the longest people are on it is about 24 weeks, pardon me. There's no real limit to the attempts. We've had people who have who's had a number of attempts. Most of the time, the thing that limits them is cost. A lot of times, and I don't quite understand this when it comes to people's drug plans, but a lot of times people's drug plans will put a limit on how much they'll pay for smoking cessation, which kind of boggles my mind, considering that smoking cessation can lead to them actually accruing less costs down the road. If they continue to smoke, then this drug plan is going to have to cover high blood pressure medications and cholesterol medications and emphysema medications and puffers and whatnot, which are never cheap. So there's no real limit on how much, but a lot of times people won't want to pay for it, so that generally limits them. We got one here.
Sorry, Steve.
Yeah, it's okay. Yeah.
I'm just going to interrupt for 1 second. This is Nicole. I'm just going to say we have time for one more question, and then we've saved all the questions that everyone's asked.
Yep.
So after the presentation, we can make sure that we get to everyone and answer their responses. So maybe just one more, and we'll have a wrap-up.
Okay. I guess one thing I would like to say, this is not really, didn't come up in any questions, but one thing I would like to say, I'm sorry, there's so many questions, it's tough to go through them all. One thing I would like to say is that when you're talking to someone who's quitting smoking, you also do need to take into account their caffeine intake. Most of the time what happens is nicotine can actually decrease the amount of caffeine that you get from a cup of coffee by about 50%. It increases the metabolism of caffeine and has caffeine leave your system quicker. So one thing you do need to stress is if they're a big coffee drinker, much like I am, if they're at like 6-7 cups a day, they're going to need to peel that back when they start to quit smoking. They can work their way back up to it if they want after they quit, but they will notice the effects of too much caffeine if you don't have them back off their caffeine intake. So anyways, thanks so much for listening to my presentation, guys, and thank you the people that wrote some kind words on the question board. I hope you got something out of this, and I guess we'll be maybe talking in the future.
Perfect.
Yeah.
All right, I was just going to say thank you, Steve, for that excellent presentation. I find it's really hard sometimes to be engaging over webinar, and I think you really achieved that. So thank you. It was really engaging, and I think on behalf of everyone, I learned a ton. And thank you. And so thank you to everyone also who participated in the webinar. I just wanted to let everyone who participated know that they're going to be receiving an email from RNAO within the next 24 hours, and it'll link you to a short survey for this webinar. And once you've completed the survey, you will be able to print a certificate of completion off. And just so you know, all of our webinars and upcoming events are always posted on tobaccofreerNAO.ca. And just want to reiterate as well that if your question wasn't answered, we've recorded it, and we'll get back to you as soon as we can with the responses.